Welcome to Window and Level. Here we break down complex radiology topics and adjust them for clarity. I am Jenny Grick, your host, and today we're diving into interventional radiology, guided by Dr. Patrick Litam, who's completed his IR training at Cleveland Clinic. Today in our second episode, we're talking about IR fistulograms. You will know why fistulogram is one of the best procedures for the trainees to do, how to read them, why fistulas fail, and how to perform an optimal intervention. Let's go. Dr. Patrick Litam, welcome to Window and Level.
Thank you so much, Dr. Greg. I'm happy to be here and excited.
I'm honored that you accepted the invitation to talk on the podcast. Would you introduce the topic that you're going to be talking about today?
So, as an interventional radiologist, I thought that a procedure that most people have a little bit of difficulty understanding is the basic fistulogram. So, in general, I think that once you understand what the topics and terms are, and the anatomy and physiology makes sense, and then those types of procedures, which typically cause confusion for newer residents, makes a lot more sense.
I remember my first fistulogram. It was definitely a stressful thing when I did not know what to look at. My first one was actually on a lecture, and somebody was just discussing what is going on in these images, and I had no idea. Well, let's start at the basics. When a surgeon puts an arteriovenous fistula, which is what a fistulogram is for, what is actually happening?
Sure. So there are three main types of fistulas that are traditionally created by vascular surgeons, and it just depends on what part of the arm has the best vasculature for that type. The types of fistulas you tend to see would be the radiocephalic, down in the sort of the wrist area, the brachiocephalic, and the brachiobasilic in the more upper arm elbow area. And what the vascular surgeon is doing is they're anastomosing or connecting an artery to a vein so that the idea is the vein will hypertrophy and allow for blood to be removed in a dialysis machine to filter out the toxins and the metabolites that the body and kidney can no longer perform in the setting of end-stage renal disease, which is usually the indication. And that's where we come in, as we typically are called in to maintain and improve the patency and flow rates of these fistulas. And in some places, we also create them. There are some interventional radiology tools that can be used to create AV fistulas in the appropriate patient population, but that's more of an institutional preference, and a large majority tend to still go to the vascular surgeon for their AV fistula creation.
I'm curious if there's any preferences of which one is best to create, if possible.
So if you look at the Kudoki guidelines, which are sort of the national foundation that tracks the quality outcomes of fistulograms in anyone really with end-stage renal disease, they recommend going with the radiocephalic first, just because it's more distal. If that were to fail or over time become shut down or occlude, you would still have the more proximal vessels, such as the brachiobasilic and the brachiocephalic, to use as a secondary fistula. So, with that being said, it's more surgeon preference. What they typically do is they map out the vessels either by angiograms or by ultrasound or sometimes even by CT, and they decide which ones look like would be the most successful upon creation based on how close the vessels are as far as artery and vein relationships to each other.
I see, that makes sense. And you briefly touched on the flows, and that's one of the things that we evaluate on the fistulograms in IR suites. And do we have specific criteria besides the flow that will show us that the fistula is good, essentially that it's mature?
So, as far as maturity for the fistulas, some facilities have specific machines that can actually measure the flow rates within the vessel themselves. My specific institution doesn't do that. We sort of eyeball the flow rates, and if it looks like it's flying through the fistula, there's no focal stenosis or issues with inflow or outflow, vessels that are stealing flow away from the fistula, and everything is moving centrally with good patency and good speed, then we sort of count that as an adequate fistula. Typically, we use the rule of sixes. That's when you have 600 milliliters per minute flow through the fistula. And the also other six would be that you want the fistula to be at least 6 millimeters in diameter and no more than 6 millimeters from the surface of the skin.
That's very helpful. So, how do you identify if there's a failure of maturation? How does it look?
So, failure of maturation for a fistula specifically tends to happen in designated areas more often than not. So, what you would look for is either focal or diffuse narrowing, which is not the typical tubular appearance of a fistula you'd like to see. It's very raggedy and non uniform. And oftentimes you have vessels that are stealing blood away from it, parasitizing vessels, we call them, that are taking blood away from the cannulation portion of the fistula, which is where the dialysis is performed. If all the blood going into the fistula is taken away by these vessels, then the flow rates and the volume are lower. So, failure of maturation would look usually like diffuse narrowing or parasitizing vessels, usually both.
Now that makes me think that I've seen this picture quite a few times. Do you have an approximate rate based on your experience or maybe the data you have available? How often the fistula fails to mature?
I believe the percentages are about 25 to 30%. It seems a lot higher for us, but of course, we get the patients that end up falling into that category. Anecdotally, and of course, from a bias, we tend to see those numbers a little bit higher than the overall 25 to 30%.
How does it change your approach? If you see the non-mature fistula, do you send them back to a surgeon or is there something you could do?
So typically, what we would do is dilate, and it's called angioplasty, balloon the vessels to a normal size. So if you use the rule of sixes again, you want to preferably go up to a 6 millimeter balloon as your goal to dilate those narrowed portions of the fistula to a good size, usually about 6 millimeters, because that's sort of the starting diameter for a functioning fistula. And then when you get preferential flow through the mainline fistula, oftentimes those vessels that are stealing blood away from the fistula itself resolve.
What is the most common reasons why the fistulas fail and why patients come to you for a fistulogram?
I think once the patient is able to get dialysis reliably for about 2 weeks or so, about 6 sessions, we would consider that a successful maturation. And then at that point, you would sort of enter the maintenance phase. You have to remember that a large, overwhelming component of the fistula, almost all of it, is venous. And as you get more flow into these veins from an artery, they tend to hypertrophy. And as they hypertrophy, they will become focally stenotic. And this almost always happens in the venous outflow. And those require angioplasty. And I would say once you enter the maintenance phase, it's usually about 80% of the time, it's going to be a focal stenosis in the venous outflow. Now, one thing I do want to mention is that a lot of these findings that you will see on the fistulogram when you are in the procedure can be predicted based on the physical exam. So, when a patient comes in, you want to get as much information as possible. You want to see what kind of fistula or graft it is. You want to know how long they've had it for. You want to know how it presents when you palpate and auscultate the fistula, and that'll give you an idea of what to expect. So, a patient that has arm swelling and central swelling in the neck is usually a stenosis all the way in the central component, usually in the subclavian veins at that point. If you have pulsatility over the fistula, that's usually a outflow stenosis, usually at least one, sometimes more. And I think it's important to mention that when someone hears the word thrill, they think that's always a good word. It just has this connotation that everything is fine in the fistula, and that's not necessarily true. The only type of thrill that you want to have for a fistula is a continuous fistula over the anastomosis. If you have a thrill over the venous outflow, that's not a good thing. If you just have a thrill over the systolic part of the cardiac cycle and not over the diastolic portion, that's not necessarily a good thing because it implies that there is a stenosis, and that's why you can't get this continuous thrill. Thrill doesn't always mean everything is perfect. It just means that it's probably better to have a thrill than to not have it. But, as far as terminology goes, it is important to know that the physical exam can predict what you expect to see. And you'll have the appropriate equipment to accommodate whatever you plan to do.
So we are at the point where we do a physical exam, but let's track back to a day before. You have a patient scheduled for a fistulogram tomorrow. Could you walk me through your preparation for a fistulogram?
The first thing I like to know is whether the patient has had fistulograms in the past. That's usually the best reference to plan the fistulogram for tomorrow because it'll usually tell you where the patient's problem areas are. Most of the time, you get all the information you need. While there's only three main types of vascular surgery AV fistula creations, as they age, they may require some sort of surgical revision. They may have an old fistula that's right next to another fistula and or partially involving it or connecting to it. Some bizarre, unexpected type of anatomy or surgical change that you wouldn't know unless you looked at the prior images. So I would start there. And then if there was a focal stenosis on the prior study, that's what I would expect would be the plan. You can also look at the size of the angioplasty balloons that they used and decide if you want to go straight up to that size and or go a little bit bigger. It'll also help to determine the direction and the site you want to get access, whether you'll need one or two, and whether you'll need to plan for possibly an embolization or a stent. Make sure you have that equipment available, which most institutions would have. But in addition to looking at the images, which gives you probably 99% of the information you need, I would also check to make sure I knew what the indication was. And more often than not, it's for difficult cannulation or low pressures during dialysis, which implies venous outflow stenosis an overwhelming majority of the time. And also, you'd want to make sure you check the patient's potassium. You want to make sure that they aren't in a situation where they're having a potassium that's too high that can cause cardiac arrhythmias. That's more of a declot concern. But for fistulas, it is something that I look at if they have it. But I wouldn't necessarily order a BMP just to get that number specifically for a standard fistulogram.
So, what you're saying is that it's very common that these problems just recur. Is that right?
Mhm. That's correct. Yes. When you start to get these areas of stenosis, they tend to recur because the angioplasties are sort of temporary measures. You keep doing that until you cannot resolve the stenosis with the angioplasty. And at that point, you consider stenting. Sometimes with drug coated assistance, doxorubicin is the um, medication that would be on some of these drug coated balloons that would help to prevent intimal hyperplasia. I don't usually use those balloons unless there's a foreign body in the fistula that I'm treating. So that would be either a stent or, in the case of a graft, those are things that I might consider using in those types of patients. But yes, the typical expected treatment requiring portion of the fistula would be the area that it was causing errors in the past.
And you mentioned stenting. Is that something that you try to delay, or how do you define if this fistula has indication for stenting?
Personally, I try to push off the stent as much as possible. And that's because I feel that once you have the stent in place, the level of intramural hyperplasia that you get tends to occur at a much faster rate, requiring more interventions. And oftentimes at that point, the only reasonable alternative to treat that stenosis is to extend the length of the stent. As far as the indications go, you don't want to consider stenting until you have 30% sort of residual stenosis that you can't treat with angioplasty alone. So, and the stent that we would use would be, and of course, this can vary by institution, but what we use is usually the stent graft, which means that it's a stent that's covered and it's self expanding. It's not one of those balloon expandable stents, it's a self expanding stent. And that's also good for treating complications that could occur during the fistula.
You mentioned there was an extraordinary case that really made you think thoroughly. So, can you tell us a little bit briefly about what happened then?
Sure. Actually, one of the most interesting cases I've had was a patient that had a fistula for about 5 years and it stopped working over time like they naturally do. And this one ended up coming back to us, and we noticed that there was no outflow in the fistula itself. So this fistulogram ended up becoming a declot. That's where we remove all the clot in the outflow or venous portion of the fistula. When we regained flow, we noted that there was a focal area that was really narrow that needed angioplasty. that did not allow it to remain resolving its stenosis. So we had to stent it. And when we stented it, we noted that all the inline flow was coming out of this really large vein. And that vein we had to ultimately embolize because it was the reason why the fistula went down in the first place, but also why they thought that it was still usable because there was flow moving through the fistula, but not technically in the direction that was created. It was all coming out of these really large parasitizing vessels. So this case went from a fistula to a declot to a angioplasty to a stent to an embolization. And sometimes that happens. And once you do that, usually these patients have really good patency rates for these types of interventions. Usually the goal is to have them maintain patent for 6 months, usually in the 60 percentile is the goal per the Kidoki guidelines again. The unique thing about this case that I've never actually seen before is that when you did the physical exam, you wouldn't think it would be a declot because there was still a thrill and pulsatility. Multiple other fistulas that were performed on this patient didn't seem to notice that this vessel was stealing blood flow away from the fistula because it was sort of overlapping. You couldn't really tell. You would have maybe just thought it was a vein that was connected to the artery after the fistula. Now, that large vein was the reason why on physical exam you would think that it was still patent because it was so large. It was probably, I would have to say, 8 or 9 millimeters when a standard fistula is usually 6 to 8. It was much larger than your standard fistula, and it was taking all the flow away from the inline flow. So that was the only time I've ever seen a declot happen when you would think that the fistula was open because this thing was just so massive. It pretty much became its own really collateralized, tortuous fistula on its own. And it was functional, but very, very slow flows because the flows were going all over the arm and not, straight to the heart, essentially. So that case was certainly a surprise. And I think, one of the things that I like about fistulas is that they really allow an interventional radiologist or trainee to test their skills and practice their skills in practically everything you would need to know as an interventional radiologist. You get access in a transverse orientation. You're using wired catheter work. Oftentimes you'll stent. You're often embolizing. You're having to do angiograms. You're having to dilate with balloons. You'll have to make these decisions that involve sort of the physiology of both arteries and veins. You're going to use different projections and angles to get good pictures. While most fistulas are pretty straightforward, you get access, you plasty, and you're done usually within 20 minutes, 30 minutes. They can become a rather involved case. And because fistulas tend to be rather robust, you're not going to typically harm the patient. I do really like fistulas because they can be used to train people who are interested in interventional radiology in many, many different ways.
This is fascinating. It really makes me think that a fistula is an ultimate case you want to train and master if you're trying to be an interventional radiologist. Thank you so much, Dr. Litam. Thank you for being our inspiration, my inspiration for interventional radiology education. And once again, I'm happy to have learned from you something new and now together with the audience.
Thank you, Jenya. It's been a real pleasure being here.
If you could go back to a time when you were a resident, just in the beginning of your career, what one piece of advice would you give yourself?
Hmm. I think as a resident, looking back, I would have liked to take everything every attending told me a little bit more seriously. I think it's really important, and not even just the diagnostic component, but the interventional radiology component. You want to know how to do different procedures in different ways. Not just for the Fistulogram, but for example, the port placement in interventional radiology. You're going to see that very often. Every interventionalist I've ever met has a little bit of a difference in how they place ports and how they expect you to place ports. And as a resident, it's hard to know if you have 6 different attendings, you have to know 6 slight variations of how to place the port. But when you get out there in the real world and you're in a situation where the patient has an odd anatomy or something you have to accommodate, and the way that you place ports is different and may not work in this patient, you'll have to know another way to do it. And I wish that when I was a resident, I took more of those to heart, knowing other people's approaches, because it does make you a better interventionalist or radiologist to know how much more approaches you can have. Ultimately, everyone makes the right decision. Some may be a little bit more straightforward and maybe easier or less involved than others and accomplish the same goal. And for the diagnostic radiology residents, there are going to be different perspectives and dictation styles for all of your staff. Some are more direct, some are more minimalist, some are more maximalist. There's something to learn from everybody. They may not be your preference or style, but I can say that looking back, I've learned a little bit of something from every attending when I was a resident, even if it was someone that I may not have been as comfortable with during my training phase. So, in summary, keep your ears open, listen, learn from everybody, and acknowledge that to become an interventional radiologist or a diagnostic radiologist takes a lot of effort, a lot of study, a lot of experience, and everyone has gotten there with hard work and has succeeded and has something to teach.
Thank you. I love your response. It's helpful when you try to understand everybody's ways and everybody's approach, and based on that, build your own system. Thank you very much, Dr. Litam. Hope to see you again on Window and Level.
Likewise, looking forward to it. Thank you.
And this is our episode on IR Fistulograms. I hope this brought more clarity into this procedure and how you will approach your next fistulogram. And now for you, what are your most and least favorite IR procedures? Let us know in the comments. If you found this helpful, please subscribe. This is Window and Level. Thanks for listening.